Hello, everyone. This is the third lecture of our 5-lecture program, and in my opinion, is the most important one because we will explain now the Baruti Demiraqi approach, the new paradigm shift in modern orthodontics. So it's periodontally accelerated osteogenic orthodontics combined with blood concentrated growth factors and sticky bone or sticky tooth. Why we must talk about corticotomy? We explained the theory in the first 2 lessons, but however, it needs to be revised and re-emphasized. What's happening in nowadays situation? The soft diet that people are using more and more nowadays brought to low loading in the teeth. So less opposition of the cortical bone, more resorption of the trabecular bone. This brings smaller jaws. This brings to the problems of malocclusion. And this brings to the growing prevalence of crooked teeth and the high demand for orthodontic treatment in all ages. And all of them are asking for a short time of treatment, but also a safe one and without the side effects of the normal orthodontic treatments we're seeing nowadays. Perhaps 10 or 15 years ago, you would go on with the treatment and you wouldn't, worry much about what's going on at the end because we didn't have the CBCTs to control what was going on. But nowadays, it's a little difficult to, check a patient without a 3D exam and doing this type of treatments without knowing 3-dimensionally what's going on in the bone and the soft tissues and where we can go. So we want to treat a patient, but if there is no space, if the alveolar process is too narrow, all the orthodontic tools like giving torque, controlling protrusion, etc. will be inefficient because of the simple fact that there is no bone. So like in these cases, as you can see, where is this tooth going to move? Orthodontic forces are applied in only inside in a tooth that is moving inside the bone. But in these cases, if you will remove this tooth, we'll get outside the bone. It's no other explanation. And this is why we are seeing that lots of complication after previous orthodontic treatments, even ours. So it's not that we are immune to this. We will show you a case of many years ago, now in the continuity to make you understand what's going on. And when we go and treat a patient like this, why don't we perform orthodontic treatment and gingival coverage? Or better yet, why don't we do even a bone augmentation to improve the hardness of tissues so that we have a stable orthodontics and we have a long-term positive effect and the patient will not suffer from it in the future. So we used the corticotomy procedure, combined it with blood concentrating growth factors and sticky bone and or sticky tooth, depending on the case. And this was the modified periodontal accelerated osteogenic orthodontics approach by us too, because this is what we did in the last 10 years. The treatment time as a bonus is reduced, but it is just a bonus. It's not the main treatment plan. If you see this seminars in orthodontics from 2012, it is written exactly this. The aim of this treatise, using critical rationalism and analytic commentary, is to chronicle the historical techniques which have evolved into orthodontic tissue engineering and stem cell therapy, and first synthesize a redoubtable 21st century biology into a protocol that is comparable with any style of traditional biomechanics. Well, in this treatise, it's not what was going on, but in ours, it is exactly what we are trying to do. In 2014, we published and lectured for the first time our approach in cases with thin gingival biotype and lack of bone. And the protocol includes criminal examination. 3D CBCT is a must before the treatment, all the necessary blood analysis to see the situation of the patient and try to improve its previous pre-surgery situation. And then anesthesiologic evaluation in most of the cases happens because of the fact that the treatment is long, and normally we don't want to exceed the norms of local anesthesia, and we want that the patient takes this experience as a positive one and doesn't remember much of this situation. During the surgery, corticotomy is performed, and BCGF, sticky bone or sticky tooth, is inserted. Orthodontic treatment or orthodontic surgery can follow the treatment in the same moment or even later on. And at the end of the treatment, we have a 3D CBCT to control the result that we have. Normally, the treatment time is very short. And we had a recall of every year for at least 5 years, and many has got it even for more, as you will see in the cases we will treat in lecture 4 and 5. Patient selection criteria. Both the orthodontist and the periodontist surgeon would have to agree upon the need for corticotomy, treatment plan, and the extent and location of the cuts. This procedure has been shown to be particularly effective in treating moderate to severe crowding, class 2 malocclusions requiring expansion, extraction, mild class 3 malocclusions, as long as healthy periodontium is present or created. Periodontally accelerated osteogenic orthodontics can be done at any age. Ages from 11 to 77 has been taken in consideration because there are cases of this, as you can see in the bibliography. Preoperative considerations. We should take patient consideration, its expectations, and he should very well be informed. There is a written formation that we give to every patient before the treatment, so they understand what is going on, how it is going to be done, and they get all the information needed before the surgery. Of course, other preoperative considerations to be taken are the patient's state of health, which of course has to be taken in written, anamnesis, clinical considerations, laboratory considerations in all the cases, and just in case it is needed, interdisciplinary consultations are also done. About the preoperative assessment, we have the clinical assessment and the radiological assessment. Till and the Wilco brothers' presentation of the PAAOO technique showed the main advantages of it compared to traditional orthodontics, with an increase of tooth movement rate and limits, a decreased need for extraction, decreased treatment times, increased alveolar volume, and a more structurally complete periodontium, correction of the pre-existing bony dehiscences and fenestrations. This is of course true, but in our approach, the main indication is not the short treatment time, as I told you. It's an advertisement, but and it's of course very well expected by the patient. But the main indications are leak of coverage of the root of the teeth with cortical bone and leak of the room in the alveolar bone to move these roots of the teeth. About the clinical assessment, once again, we have extraoral examination, which should be undertaken, particularly noting the regional lymph nodes, swellings, mouth opening, which is very important in the treatment. Intraoral examination should include general status of the mouth, presence of focal infections, swelling, sinus tract, presence, quantity, and quality of restorations, caries, cracks, and so on, possibly all corrected before the surgery, because the surgical treatment makes it much more difficult for the patient to treat it. Quality of the restorations, marginal adaptation, aesthetic, history of dissemination of crowns and bridges, and so on. Periodontal status, including the presence of isolated increased probing depth. Occlusion relationship, is the tooth functioning unit, or is there a potential for function? Sensibility and percussive test for every tooth, adjacent teeth, contralateral partners of each and every tooth in the mouth that we are going to treat. The orthodontic protocol in this first clinical visit concludes palpation of the jugular surface to check the roots of the incisors, canines, and premolars and molars, of course, evaluation of the gingival biotype, state of the motivation of the patient, main radiological examination, which would be a CBCT and the cephalometric X-ray, as we will explain now later. If you can see here, this is a case of 2005, treated by Dr. Baruti. Mouth breather and snoring, class 2 division 1, V-shaped maxilla, as you can see from the pictures. This is the pre-op situation, so the pre-orthodontic situation. And this is the situation extraorally of this young patient. Treatment with orthodontics, normal one, acute, but as you can see, already you can see this type of situation, which is common in many orthodontic cases, which at the end, after 17 years, brought to this situation here. These are the intraoral photos done this year, and as you can see, there are many periodontal problems just to be seen, but also this is the situation of the patient. And this is the CBCT, where, as you can see, there is a very extensive lack of bone everywhere. So this has brought to the situation where we are now. We have lack of bone, lack of soft tissues, and the patient is going to undergo a series or treatment trying to enhance both of them, which if a possibility of our approach would have been possible at the time, would have brought to these consequences. Now the patient is adult, but as you can see, this is the intraoral, this is the situation in the CBCT where there is extensive lack of bone, which will not make her situation improved because she is now a young adult, and this is not going to have a big, very long life as these teeth are going. Radiological assessments, as I showed before, dental phantomogram, which is not always necessary because if you do a CBCT, it is of course covered, and if even cephalometric examinations are mostly covered in the new generation of the CBCT, so you can from a 3D CBCT also extrapolate the cephalometric examination. But just in case, cephalometric examination and 3D CBCT is a must in our kind of treatment. Never start a treatment in our approach without a high resolution 3D CBCT. This is a dental phantomogram, as you can see, the cephalometric examination and then the cephalometric measurements, and the CBCT, which, as we all know, has become an essential imaging diagnostic tool in orthodontics. There is an indisputable acceptance of the 3D imaging, which is far superior to the diagnostically through the 2D imaging. CBCT provides more information to the clinician regarding analysis of teeth, peripheral anatomy, periapical root pathologies, and much, much more. CBCT imaging also works as a scaffold for newly developed guiding and dynamic surgeries. CBCT imaging is also embraced in academics and from most key opinion leaders all over the world. This is what you will find in the cuts of CBCT in different plans. Lots of examinations can be done with a single CBCT, and if you have a 3D like this is also a comparison of a pre and post-op situation in one patient, like the one I showed before, after extensive grafting of hard and soft tissues were done. So as you can see, you can compare very well the situation with the CBCT in the future and in terms of volumes and quality. Orthodontists have routinely treated patient malocclusion by applying forces in all three planes of space. For years, these three-dimensional movements were diagnosed and treated with plans based on two-dimensional imaging. Is it normal? You have to think about it. The orthodontic periodontist should be very well informed of the recent innovations regarding this technology and be able to inform the patient regarding the risks of radiation exposure, as well as fulfill the necessary diagnostic approach. What I'm talking about is the fact that radiation exposure is so low compared to the much information given, and of course it exceeds many times the risks from radiation. A CBCT, a normal CBCT, has much less radiation than a CT scan done for every other possible imaginable treatment in every possible other field of medicine. And the information obtained from the CBCT requires also a substantial level of expertise for correct and precise interpretation. This is really to be emphasized because you can get a CBCT, but if you don't know what you are looking, everything is futile. Orthodontists and periodontist surgeons should have experience. Inadequate experience brings the danger of misinterpreting the CBCT image, resulting in overlooked or false positive diagnosis. This is a bibliography of 10 years ago, but it's still very much, effective. The prevention of this risk only becomes possible when these professionals are regularly being updated with the necessary knowledge, and the technical and clinical experience is vastly improved. A big field of view is a must in our approach. We normally use the 17 to 13 centimeters CBCT, but more than 12 times 10 is a must if you want to see hard and soft tissues in our field of view, but also in the nearby situation. High kilovolts of over 90, possibly high milliamperes, are indicated for this approach because they can decrease the CBCT artifacts and improve the overall quality image. The longer the acquisition time, the more base images are obtained, and the higher the CBCT scan resolution will be. So use the best you can get to have a very good pre-operative situation so that you can use it to treat the patient as well as possible. After the evaluations of all the examinations, we explain to the patient in terms of mechanical movements and in terms of surgical aspect that teeth need to move to the in the alveolar bone, and the lack of the space makes it impossible without getting out of this alveolar bone. A brief description of the clinical and practical advantages of the procedure is explained, and with actual photographs, and the actual procedure is explained in other previous patients. If it is possible, of course, we try to meet new patients with the ones that had this experience before, because this is the best way that they can understand what was going on. Corticotomy assisted orthodontics is sometimes an invasive surgical procedure that requires the elevation of buccal and often also lingual palatal flap for decortication of alveolar bones, followed by bone augmentation. The most frequent reason that the patients are perplexed about corticotomy is the fear from pain. Showing the pictures of before and after of other patients, making possible that the previous patients speak with them to share their own experiences about pain and edema after the surgery procedures, is very much needed to make them sure that not much has happened. In our many years of experience, the patient had the use of anti-inflammatory drugs already the night of the intervention. Of course, anesthetic treatment includes inflammatory drugs, but afterwards they have just an edema which is dissolved in less than a week, so 4 to 7 days is the norm, and you will see it in lots of cases that we are showing you that this is the norm in this situation. Necessary blood analysis. Complete blood analysis with the leukocyte formula, leukemia, uremia, creatinine, transaminases, total bilirubin, and vitamin D levels are always asked from the patient. And of course, quick tests for hepatitis, HIV, and many more if the patient is a risk one. Because, as I told you, many of these patients are adults, and of course, they are not immune from other disease. If it is needed, interdisciplinary consultations such as pulmonary X-ray, AKG consultation in cardiac disease patients, other necessary interdisciplinary consultations are done according to the conditions of the patient. Normally, this is now what we actually try to extrapolate from each patient. These are the analysis. As you can see, this is what we ask now before our treatment. Since we are going to do enhanced hard and soft tissue graftings, it is good that we have a good knowledge of what we are having before the treatment. Preoperative examination includes intraoral and extraoral examination. The preoperative medication, given the entity of the treatment and the combined orthodontic surgical treatment, hygiene is more difficult, so we recommend the use of systematic antibiotics for 5 to 10 days, metronidazole plus spiramycin, or amoxicillin plus clavulanic acid is used most of the time, and others, in case patient is allergic to some one of this, can be used. The use of mouth oral rinses is very much suggested and explained to the patient to reduce plaque formation. We use the Blue M line of products in our clinic for many years, but it doesn't make you do this, but it's a good line of products that we use. Systematic non-corticosteroidal anti-inflammatory drug therapy should be considered prior to surgery in order to reduce post-op pain. About the pre-operative preparation, pre-operative hygiene is a must, and it is done prior to the surgery, 1 or 2 days, in order to have the best possible conditions in the mouth. As I told you before, all the treatments, such as therapeutic treatments, should be possibly done before the treatment of surgery and orthodontics combined. So in our approach, as the patient is needed to have the best possible intraoral condition before the surgery. Our surgical set includes many armamentarium. As you can see, since we are using piezo, many piezo type of instruments are used, and the BCGF kit that will be shown now in a couple of slides. The standard surgical sets, the most important thing to have in mind in surgery is the field of view for the patient. So this is retractors we use to make this field of view seen. Different ones you can use. The Optra is the first one. The other one is very nice also. And this is the normal one that every orthodontist uses to take pictures, but in many cases it can also be used during surgery. We also use illumination, magnification, recording. I started using LED lights and then this kind of lenses before, the 3x ones, and now we are going to till 6 times. If we are going to do a good treatment, we have to be able to see very well. About the rest of the procedure, all of our procedures are recorded with this system since 2016. So it's like 6 years now. We have high quality videos in full high definition, and broadcasting is possible. And you will see some small videos like this one here of an actual corticotomy procedure. So this is actually what is going on. It is a case, an old one, but of course, as you can see, the imaging quality is very high. This is my operative room. As you can see, plenty of instruments are there. Jonathan is the big table over there with 2 working spaces. Things, as you have seen, many instruments are needed to be used, but of course it's not a must. It's what we use, but it doesn't mean that you have to use everything that we have. These are the 2 plans of work. There is extraction and non-sterile stuff done, and also the sterile part with the bone grafting and so on, which is done then at the end, in order to keep these 2 planes separate from one another and not make contamination in the sterile one. Anesthesia, as I told you before, where possible, local anesthesia is used in small cases, but normally we use intravenous sedation, and hemostasis is of a benefit in the surgical side, and this, of course, easily achieved when we use a local anesthetic containing a vasoconstrictor, so it is most of the time used. IV anesthesia is used, and of course, local anesthesia in this case is the same, and the tracheal intubation can also be used if the case is particularly long, or if the patient is particularly, so to say, anxious and so on. But in 99% of the time, we are using intravenous anesthesia. X-ray examinations are done, consent from the patient, blood analysis, chest X-ray. The anesthesiologist examines the patient prior to the surgery, of course. The bondings of the brackets are done before the surgery. And before, it means the day before or a couple of hours before. And this is the procedure, the surgical procedure, step by step in the Baruti Demiraqi approach. Incision of the mucoperiosteal flap, reflection of it, exposure of the working field, the performing of the corticotomy, additional surgery needed, extraction, apicectomies, etc., the toilet of the wound, bleeding control, hard and soft tissue grafting, closure of the surgical wound, suturing, and of course, post-operative instruction, medication, and care are given and explained. Directly after the surgery, orthodontic treatment starts with the placement of the wires and using of high torque and high values from 50 to 100 gram in this case, because we want to profit as much as possible from the RAP. So in this presentation, the indications are resolve crowding and shortened treatment time, open bind correction and molar intrusion, manipulation of anchorage, facilitating the movement of the teeth with internal root resorption, facilitating the movement of teeth with delacerated roots, and dip bite and canting correction. As shown before, many pictures of Modigliani will be shown presenting the cases, because he was an extraordinary artist, and in the letters he wrote from his sabbatical in Capri in 1901, he clearly indicates that he is being more and more influenced by the thinking of Nietzsche, and in these letters he advised his friend Oscar Giglia, hold sacred all which can exalt and excite your intelligence, and seek to provoke and to perpetuate those fertile stimuli, because they can push the intelligence to its maximum power, creative power. So let's start with some clinical cases, resolving crowding and shortened treatment time, corticotomy with BCGF membrane coverage. The patient is young, 14 years old, female, class 1 malocclusion, insufficient cortical bone coverage to the teeth roots on both jaws, with very thin biotype of gingiva. The treatment proposed was extraction of 41, because it was really out of the arch, and there was no place to recreate that and to put it inside the arch. Periodontally accelerated osteogenic orthodontics was used with blood concentrated growth factor membrane coverage, and the treatment time had a total of 3 months. In young ages, this is what you get with our type of approach. This is the pre-op extraoral situation. As you can see, the 41 is really outside of the bone. So also the place was so minimal, and also the patient was asking for the treatment time to be as fast as possible, because she was living outside of our country. So we did our best with what was given to us and what was requested from us. This is the extraoral view and the CBCT reconstruction, as you can see, very nice. And this is the CBCT 3D reconstruction without the soft tissues. CBCTs are getting more and more complex and doing our work very, very easy. As you can see, this is 41. That's really outside of the bony envelope, but the problem was the fact that there was no place to put it inside, even with a big amount of time. And the patient didn't want to do extensive grafting. So the other problem was, even if we tried to put it inside the bone without grafting, it wouldn't have been so much successful. So we proceeded as requested. Corticotomy was done in both arches, and as you can see, the removal of number 41 was executed during the treatment. BCGF membranes, plenty of them, like 12, I believe, or more. So it's like 120 milliliters of blood, which is not a big quantity if we measure the fact that in one blood donation you do like 250 milliliters. So it's nothing important. Even with the quantity lost in the operation, the quantity is never that much. BCGF membrane coverage in both jaws. It was then serum was used, and then the BCGF membranes were placed. As you can see, plenty of blood. This is the edema of the first, second, and third day. As you can see, nothing important and nothing extraordinary to be seen. After 2 weeks with the Baruti Demiraqi approach, as you can see, the situation is much more improved. Heavy forces are used, as you can see. And in 4 weeks, this is the result. It's almost done. And we wanted to, see what was going on inside. The bone regeneration in the alveolar side, due to the fact that it's in the young age, and many authors have predicted that bone regeneration was very extensive in this age. As you can see, you can almost not find the corticotomy sites, and also the alveola of the 41 is very difficult to be found in only 1 month. This is then 1.5, so 6 weeks after our approach. As you can see, it's almost fully aligned. And this is the situation at 3 months, so 12 weeks done. Everything is in place, patient smiling happy. Notice the gingival improvement, thickness, color, vascularization, all are improved after the treatment, and no roots are to be seen outside of the alveolar So the Ugaldo layers you can see above are not to be seen below. Frontal view also. And this is then the follow-up after 1 year. A pretty stable result, as you can see, extraorally and also intraorally. This is the CBCT taken after the orthodontic treatment. As you can see, the improvement in the frontal area and the cuts that shows all the improvement, and all the teeth are to be found inside of the bony envelope. So as you can see, everything was corrected and there is plenty of hard and soft tissue around this teeth. This is the 1 year follow-up, the 3D CBCT control. This is the before and after the orthodontic treatment. And this is also before and after the orthodontic treatment in the cuts, where you could see the roots before outside of the bony envelope, and afterwards they are all inside, alineated. And this is a stable result in 1 year after the treatment. This is the extra oral views after 1 year, and this is the result after 3 years. Really stable, patient really happy. Another case of crowding and shortening of treatment time. Female, 21 years old, skeletal class 2 malocclusion. So as you see, most of the patients requiring orthodontic treatments are female, but also just keep in mind that it is said that it's a very dramatic and very fearful treatment. But as you can see, most of the women in these situations undertook it without big problems. So we have a class 2 malocclusion, insufficient cortical bone coverage of the teeth roots on both jaws, unilateral crossbite at the left side. The treatment during the corticotomy with the periodontally accelerated osteogenic orthodontics, also BCGF, and we extracted 3 wisdom teeth, but at the time, it's like 7 or 8 years ago, we didn't have the grinder, so they wasn't used. The treatment time in this case was just 8 months. This is the pre-op situation, extraoral view, the 3D CBCT, and reconstruction with hard tissues and hard plus soft tissues. This is then the full reconstruction of the soft tissues in the case, and this is then what we have inside the mouth. Notice the premolar outside of the arch and crowding in the frontal region, in the maxilla. The 3D CBCT at the beginning of the orthodontic treatment. As you can see, many teeth are outside of the bony envelope, which made it impossible to be treated with the normal way. So the normal orthodontics would have much worse in this situation, so we decided to go with corticotomy, as explained before. As you can see, the brackets are placed before the surgery. These are the corticotomy cuts, upper and lower jaw also. BCGF membranes placed everywhere. It's like 160, if I'm not mistaken. And the 3 not fully formed wisdom teeth were also extracted at the same procedure time. This is the maximum edema at 72 hours. So if someone didn't know she performed the surgery, no one would have guessed this is the face of a patient after 3 days of this type of extensive surgery. The orthodontic steps, the step-by-step procedure of the orthodontic treatment, as you can see. I'm giving you the time to appreciate the steps. All types of orthodontics can be used during the treatment, and as you can see, many of the steps were done with sutures in mouth, which can be removed till 3 weeks after the treatment. So a couple of times the patient had to change wires and so on with sutures in. So the sutures has to be very firm, and the suture technique is not important. The important stuff is that the suture technique secures that the tissues are in place and they don't move, which is very much possible in this type of treatment. This is a situation then after the alignment, after 5 months perhaps, and this is that 8 months after removal, retainers were placed. As you can see, the situation is stable. Patient's hygiene is not the maximum, but we do whatever we can with what is given to us. This is the pre and post-operative situation. As you can see, the smile is much improved. The patient is happy. The 3D CBCT after the orthodontic treatment, as you can see, shows all the teeth inside, the inclination of the frontal region. Incisors are pretty much inclined in the right position. These are the cuts, showing everywhere bone, no roots outside of it. So the before and after treatment comparison. The after CBCT is done before, just before removing everything, because we want to see the result and then remove the brackets. This is then the post-op situation. As you can see, everything is stable and improved. Gingiva is improved with thickness, color, vascularization, and lateral view also. There is no loss. In the contrary, it is gained. even with these big flaps that we are using. And this is then the 7 years follow-up. As you can see, this situation is admirable. I believe everyone would agree. And this is the CBCT after 7 years, the 3D reconstruction, showing everything as before. And this is then the patient smiling and intraoral view at 7 years follow-up. And this is then the extraoral, everything nice, and the patient is happy. Another one, BCGF and sticky tooth, a 16-year-old female, class 2 division 1 malocclusion, high angle, bilateral crossbite. So it's not just the crowding. In this case, it's pretty much very stuff that would make every orthodontics, fear if the treatment was going to complete. We have very thin gingiva and insufficient cortical bone coverage. Anterior open bite, V-shaped maxilla. It's a mouth breather, frontal tooth densification with vestibular roots exposure, bimaxillary in the frontal area. The treatment plan, first she was treated with RPE of a rapid palatal inspector, expecting the McNamara type, expander, extraction of the 3-rooted 14 and 24, which were inevitable in this case, but notice they are 3-rooted. Periodontally accelerated osteogenic orthodontics with immediate bone grafting, sticky tooth, beta-calcium triphosphate 60/40, and BCGF membrane coverage. This is the pre-op situation extraorally, and this is then the pre-op situation intraorally. As you can see, the situation is dramatic. The 3D CBCT taken showed the maxillary 14 and 15 with 3 roots, and also 24 and 25. So it was no space for both of them, and as often happens, the first premolars are sacrificed in order to make place in the mouth for everything. Please check the previous lectures. So this is the McNamara type device to open the midline. This is the situation after this treatment. So this is then before we started the traditional corticotomy as in the other cases. As you can see, there is much improvement already. So there is much more space where we can work. However, it's not sufficient for all the teeth that we are trying to alienate. Brackets are placed before the surgery. Extraction of 14 and 24. Very nice pre-rooted premolars, which were then grinded and made sticky tooth. As you can see, there is a plethora of BCGF membranes over there, the white buffy coat. It's perhaps 160 or even more, and a big quantity of sticky tooth in this case to cover everything, because as you have seen, there was no bone to cover these teeth. So piezo surgery, as always shown. This is the situation after the piezo surgery in the upper jaw. Sticky tooth everywhere and BCGF membranes to be placed above them. The most important place where we put them is directly above the papilla, in order to improve the quality and the quantity of the soft tissues at this site. This is then the mandible. Of course, all was done in the same session. And this is then the situation after grafting and suturing everything. Directly afterwards, the orthodontist starts the treatment with whatever means she finds necessary to move the teeth as soon as possible. This is the maximum edema at 3 days, so 72 hours. As you can see, nothing important. This is then during the treatment, still sutures in the mouth, and as you can see, there is no problem using the orthodontic forces if you do a good suturing technique that will allow you to keep them steady. Already there are much improvements in the soft tissues and hard, of course, if you can see. This is then at the end of the treatment, the pre and post-operative situation, which is, so to say, it speaks for itself. We have improvement overall, thickness, color, vascularization of the gingiva, hard tissue, much more to be found. Lateral view, same situation. And another one in the frontal view. So after this type of treatment for about 8 months, you can see the dramatic changes in the patient. These are the roots of all her teeth, everything inside the bony envelope. This is the incisors. As you can see, there is new bone everywhere to cover them, so they will be there for a long, long time. Sticky tooth is one of the most efficient grafting situations I have ever tried. of course, if combined with the right biomaterial, and of course, possibly with a little bit of autologous bone. And this is the cephalometric. As you can see, it's less than 1 year from one to the other. So it's 11, 17, and it's so November of 2017, and then the other one is August of 2018. And this is the situation in the 3D after the surgery. As you can see, there is bone everywhere. This is the situation extraorally after the surgery. The patient is really happy. Another case with open bite correction and molar intrusion. EAOO with BCGF and sticky bone was used in this case. The patient was a male, 32 years old, referred to us from the prosthodontist because of the lack of space. Polydiastema into the upper arch, very irregular occlusal plane. Intrusion was needed in the first and second quadrant. Very thin gingival biotype and insufficient bone coverage of the roots of the teeth. The treatment in the first stage included corticotomy and in the maxilla with BCGF, and in the second stage, implant placement, apical resections, implant placement number 22 and 26, resections in the 35, 45, 46, and the third stage. So the rest of the treatment was handled by the referring team. Many cases, it required collaboration, so it's not that you should always finish a case, but it doesn't make it less successful this way. As you can see, the situation prior to the treatment is dramatic. The patient wanted a good situation, but there is so much space. And this is the type of cuttings in this case, as you can see, thick cuttings to make it as easy as possible to treat and to move them as soon as possible in the new position. Plenty of BCGF membranes used in this case. Sutures in place, and treatment started directly after I finished suturing. This is the situation, space opening, and this is then implant placement in the second stage, plus BCGF membranes and plus sticky bone, as you can see the quantity in the middle picture. This is actually an old case. It's like 6 years old now. And apical resections, which were then, of course, grafted. This is the situation in the lower jaw after BCGF membranes placement and suturing. This is the maximum edema. The third day, as you can see, nothing dramatic. This is then the situation during the treatment where the implant sites can be seen and finalized here with this situation of the implants, and this situation finished with the lower jaw with everything in place. So now the treating team started and they went on with the finalization of the case. Manipulation of the anchorage, periodontally accelerated osteogenic orthodontics with BCGF and with sticky tooth. A female, 10 years old, with transposition of 23, supranumeratum between 21 and 22, delaceration of the apex of 21. The treatment was the first stage extraction of 63 and the supranumeratum, distalization under mucosa of the 23 covered with BCGF membranes, and in the second stage, corticotomy, palatal and vestibular to 21, 22, and 23 covered with sticky tooth and BCGF, with the normal orthodontic treatment, so accelerated one as the other cases. This is the pre-op situation. As you can see, the situation is not so promising. This is then the extra oral view of the patient before treatment. And this is then the CBCT of the upper jaw, where, as you can see, there is a transposition and there is a supranumeratum then in between the two teeth, which needs to be extracted before treatment starts. This is the device, RPE in this case, with some changes and improvements to make possible the anchorage. And this is the surgery, the first stage surgery. The supranumeratum is removed between the two frontals, 21 and 22, and then there is a place created, and the direction of the traction was decided to be in the middle of the alveoli. As you can see, the tooth is very vestibular, and we try to do it as much as possible in that direction so that it could not lose much bone, which of course was thinkable at the time. And as you can see, BCGF was placed both sides to improve further the traction. As membranes, it was like 4 membranes placed. And then this is the device that was trying to, first of all, distalize it and then try to upright it and put it in position. This is the situation after the traction, and the other side, as you can see, the other canine is also coming out at the same stage after rapid palatal expansion. This is then the CBCT at this moment. As you can see, the tooth is in the right direction, but there is no bone vestibularly. And of course, if we continue the traction without doing something, then these teeth are all doomed and nothing will, make them be in the mouth for much time. And it's meant for 21, 22, and 23. This is the second surgery, partial one, with corticotomy in the both vestibular and palatal side. And of course, as you can see, there is a created place even in the midline, so that all these teeth can rapidly move into the desired direction. All the teeth extracted in the lower jaw, plus the ones that we have extracted before, were turned into sticky tooth with BCGF, as before explained. And this big quantity of bone was placed directly after the corticotomy, vestibularly and palatally, because as you have seen, there was almost no bone there. This is then the standard, so to say, accelerated orthodontic treatment that started directly after the surgery. And this is the maximum edema after 3 days. And then this is the situation after traction in less than 1.5 months. I have to be noticed that the patient, adolescent at the time, had not a good hygiene, as you can see from the pictures. But this is a typical problem in this age. And however, we managed to, upright and bring the teeth in a good position. And this is the end of the treatment. As you can see, it's very satisfactory if we measure the beginning of the treatment. This is then the post-op situation of the patient. This is the grafting situation at the end of the treatment and the all 3 teeth. As you can see, the graft is still not setted, which is normal for a sticky tooth because it's supposed to be a scaffold for many, many years. But the turnover is slow, but the turnover is sure. As you will see, this is the canine, and there is the new bone, not yet mature because the treatment lasts so little. And this is the 3D situation at the end of the treatment. And this is then the situation after 1 year. As you can see, the turnover is very much noticeable. And now this teeth has got some new bone, which will improve further in time. And this is the canine. As you can see, the situation of the bone is much, much improved if we compare to 1 year prior. And this is then the 3D CBCT cut in the outside and palatally. And this is then the in mid of pandemic cephalometric and panoramic X-ray, which, as you can see, has a very good situation. Facilitating the movement of teeth with internal root resorption. Corticotomy was performed with BCGF and sticky bone and sticky tooth. Before that, let me show what can happen in a tooth with this type of situation. This is a referral from a colleague to Dr. Baruti, male, 21 years old, under orthodontic treatment, retention of 23, and he was for 3 years under traction, which caused an iatrogenic open bite and the creation of occlusal canting. As you can see, nothing can move a tooth with internal resorption. The case was treated just with 2-dimensional figures, and no one had the idea to do a CBCT. This is the intraoral view. As you can see, the patient has gained, so to say, because all the arch was trying to retract this canine, which wasn't to be moved. As you can see in the CBCT cut, there is internal resorption, and this tooth would not move anywhere. As Professor Adrian Becker in Troubleshooting Impacted Teeth showed, orthodontic treatment of impacted teeth, 3rd edition also, the phenomenon is called invasive cervical root resorption. The phenomenon is well known to endodontists, pediatric dentists, and dental traumatologists because the prevalence of it following trauma or bleaching of non-vital teeth is relatively common. Invasive cervical root resorption in vital teeth is rare and insidious, although it is an aggressive form of external root resorption which begins at the very small site immediately apical to the periodontal attachment. Histologically, we have found in invasive cervical root resorption that in addition to resorption, there are also areas of deposit of bone in the resorbed area, and this is most likely what will have contributed to the failure. So this is what we had in this case, and the tooth wouldn't move from there for nothing in the world. This case is still in progress, but you will see another one that is already finished, just showing you the narrative of it. Another one, male, 17 years old, narrow maxilla, bilateral cleft bite, bilateral open bite, 23 retained, and 15 in palatal position, delay of eruption of 17 and 27, maxillary canting in the left side, 3 millimeters, the maxillary retruded, previously treated with orthodontics. The treatment in this case was the rapid palatal expansion McNamara time. That also helped with the piezo incision, partial corticotomy, and simultaneous defect treatment with MTA filling, a TUD was placed to retract this 23, and the orthodontic treatment also as normal. This is the pre-op situation. As you can see, nothing dramatic there, but if you see in the smile, there is something dramatic because the canting is evident in the left side, and this is the canine inside. As you can see, this is the anteroposterior encephalometric view, and this is after we did the piezo in the middle to do then the RPE treatment. This is a situation, and this is where we start to see the problem. As you can see, internal root resorption. But this is the situation after the rapid palatal expansion. And this is the situation with the resorption of this 23. Almost the same as the previous case, but in this one we were ready, unlike the previous orthodontist. So this is the palatal view where you can see it's a very big defect. So this is the situation before we decided to go for corticotomy in this region. Everything was trying to correct normally. And then this is the slide. Laser was used to expose the tooth also and to remove the sulcus. The cleaning was also done with burrs and laser of this region. As you can see, it's palatal. It's very difficult to handle. However, we managed to. And as you can see, this is the situation. Afterwards, we did corticotomy. The corticotomy cuts are to be seen, and placed MTA in that spot. And then sticky bone plus BCGF membranes and sutured with a DPTFE. This is then also some views. As you can see, the chain outside the mouth. And also this is how we placed a TUD in the lower to try to extrude the canine. This is a situation. Directly after, MTA was not much to be seen. However, it was there and was working because in a later view, as you can see, the situation is much more improved and the tooth is coming out. This is then the final situation. Of course, much can be done to improve because, as you can see, the fact that the defect was enormous caused this type of problem, which was not solved with just one surgery. And now the patient is perhaps going to do another one because it is not in our decision. If the patient is happy, he can stop there. It's with this type of lip, it can't be actually seen, that region in the canine. So this is how it ended for the first treatment. The patient was happy with his result. Deep bite and canting correction and BSSO with selective corticotomy in this case. A female, 35 years old, close locking TMJ. She could not chew the food. Pain when opening the mouth and represents a reduced function in the movement of the mandible. Mandibular hypertrophy, maxillary canting, mental deviation. The treatment plan in this case was condylar shaving, BSSO, selective corticotomy in quadrants 2, 3, and 4. So this is the pre-op situation. This kind of opening, and the patient was unable even to chew because she had pain every time she tried to chew. Extraorally, as you can see, and intraorally, this is this asymmetry, which is evident. The situation in the CBCT. This is the condylar situation in this case. The condylar cut, as you can see, and corticotomy done selectively in these sites. Then orthodontic treatment was being done after the BSSO. This is then during the orthodontic treatment, correcting it, and this is then the situation. As you can see, the situation after the treatment, and the condylar improvements are very visible. This is then after the orthodontic treatment. To fill the spaces, we would have preferred implant, but it's always the decision of the patient to do whatever they see fit. And however, this is the finishing of the case. Of course, no one can correct it 100%, but it's a very good result, and the patient can now happily eat and chew. Another case facilitated the movement of tooth with delacerated roots. PaOO and BCGF and sticky bone was used in this case. 47 years old female patient, actually a doctor, a well-known HNO doctor, But the problem is she has got some troubles, even extra orally, so to say. She suffers from hypothyroidism and iron deficiency anemia. She is missing lots of cortical bone as perhaps a result of it, but also much more. Thin biotype gingiva, anterior bimaxillary crowding, skeletally class 1, dentally right side was class 1, and the left side was class 2. We decided for fixed self-ligating growth 22 because the patient wanted to be aesthetically as nice as possible. PAOO with immediate bone grafting, sticky bone, BCGF membranes covering, with the Baruti Demiraqi approach. So this is the pre-op situation, which is not so pleasant to be seen. But the patient, no one was taking her into treatment because of all what I've showed and what I've told you. Nobody wanted to risk delusion in this case because the fact of the patient is a colic. And this is what happened when you are enough confident in your treatment plan. And this is the CBCT before the orthodontic treatment. As you can see, all the roots are outside, everywhere. The patient was extensively treated with supplements and so on to help as much as possible before the orthodontic treatment. And this is sticky bone and BCGF membranes in industrial, so to say, quantity. I believe it was like 250 or something milliliters taken in this case. As you can see, all the roots are visible in both jaws. Cuts, corticotomy style, BCGF membranes placed everywhere. Stick after, of course, the sticky bone. And the patient wanted to improve the momentum, so we, placed a big quantity in the frontal mandibular region in sort of an implant situation, of a chin implant situation, because she didn't want to, go to cutting and moving of the apex of the chin. So this is the edema, as you can see, a little bigger than the other cases, but it's legitimated by her overall systematic status. And this is then the situation during the treatment. As you can see, much improvement is already happening. And this is the post-op situation. The CBCT before and after shows the differences. You can see here there is new bone formation everywhere. And also in the lateral view, this is what you can find and see. All the roots are inside the bony envelope. The new formated bony envelope. So here too, and here too. So it's not that it's something only in one place, it's new bone everywhere. This is the post-op situation. Of course, the patient then decided to do some other changes, as you can see, veneers and so on, but we had created the situation to do so. So check it. As you can see, the 3D comparison is clear. There is plenty of bone in the post-op situation. And as you can see, directly after the surgery, because we didn't carry on with the aesthetic treatments, it's work done by another famous specialist in aesthetics. As you can see, the situation is pretty much stable everywhere. Another case, deep bite and canting correction with PAOO and BCGF and sticky bone. Female, 23 years old, very thin gingiva, supernumerary teeth in the 4th quadrant, anterior crowding, both mandibular cuspids with 2 roots. The treatment was periodontally accelerated osteogenic orthodontics with blood concentrated growth factors and sticky bone. The extraction of the 4/3 molars and number 45. It was also an old case. Treatment time 8.5 months. The maxillary cant, another doctor, actually, this one is also a doctor, is clearly visible, and the fact that all the roots are outside the bony envelope made it quite difficult for the patient to find the right orthodontist to take care of her. Without surgery, it was a little difficult, or so to say, impossible. The 3D CBCT before the orthodontic treatment, showing all the roots outside the bony envelope. And we have mandibular 33 and 43 with 2 roots in this case to, make it even easier for us, so to say. Here you can see them in the cuts of the CBCT. Laser was used for incision, as you can see. BCGF membrane everywhere after the corticotomy, in the upper and in the lower. Sticky bone also, plenty of it. Retraction of number 45 in place, as you have seen the chain. This is placement of sticky bone and also BCGF membranes. So, as you can see, it's very, very stable. You can handle it so easily, and it doesn't move from where you put it. This kind of video, non-saxon style, it's done like 6 years ago. The BCGF membranes used in the case. Okay, let's proceed. This is after suturing everywhere. And you can also notice the chain to retract number 45. But after corticotomy, it's easy. In this case, it's coming already out, as you can see, after a couple of months. And everything is almost corrected. The small corrections are then the ones that we do in normal after the first 4 months, where you can benefit from the regional accelerated phenomenon and the plus given from the BCGF technology. And this is the CBCT at 8.5 months after the treatment. Every tooth is covered with bone and soft tissues. This is directly after removal and some cleaning, so that's why the situation looks, so to say, a little messy. However, the gingival improvement, thickness, color, vascularization are to be seen. The patient smiles very happily. The pre and post-op situation. The post-op situation, and this is then the 4 years follow-up. The doctor is actually happy with the result. Another one, deep bite and canting correction, solved with PaOO and BCGF and membrane coverage. Another female, 23 years old, class 1 malocclusion, retained number 13, delacerated, missing of 22, very thin gingival biotype, insufficient bone coverage of the roots of the teeth, increased anti-speak plane in the upper arch, and a very deep speak curve in the lower. First stage of the treatment, corticotomy and BCGF membrane covering in both jaws, and the extraction of number 13, delacerated, and orthodontic treatment. Why did we decide to extract is the fact that there was no room to take it out. You will see now after we explain the intra and extraoral situation. The orthodontic treatment went on, and then we placed an implant number 23. So this is the two-dimensional situation, which doesn't seem so, so to say, impossible. But if you check the 3D, the situation is not as nice as in the 2D to be seen. So this is actually the inside of the mouth situation. And this is then the situation extraorally. This is a disastrous one and very difficult to treat for every orthodontist. Plus, combined with the lack of tissues, in this case, makes it almost a no-do case. This is then the canine, the lacerated one, as you can see. But even if it was a good one, there is no place to take it out and try to align it with the rest of it. So we decided to remove it during the procedure. Other views to show it. The CBCT allows us to do this type of treatment and to do this type of prediction before the surgery. So corticotomy, demaxillary, sticky bone, and then BCGF membranes were placed everywhere. Suturing, tight suturing, as you can see, and directly starting with the movement. Then afterwards, in the second stage, we placed an implant, number 23. The lateral incisor became canine. The canine number 23 became a lateral incisor and was brought there. And number 23, an implant was placed. This is the post-op situation, where you can see all the improvement. Also, this is the situation of the implant. And this is the post-op situation, which is not perfect, but it's a major improvement. This is then the 1-year follow-up, and this is then the 5-year follow-up. As you can see, there is much improvement everywhere, and it's stable after 5 years. So as a conclusion, the main goals of the Baruti Demiraqi approach are safe orthodontic treatment, creating room for the on-the-alveolar process, for the root movement, enhancement of the quality of the gingiva biotype, and the long-time stability. Focus that the goal of the treatment is not the shortening of the treatment time. This is just a well-received bonus. So corticotomy in all the cases combined with BCGF and sticky bone sticky tooth resulted in all our patients short time of orthodontic treatment, painless and little edema on post-operative period, a clinical and radiological visible improvement of the periodontal and gingival recession on the patient teeth. The mechanisms found behind corticotomy procedures can be summarized as bone metabolism, induction through decortications performed around the teeth which are going to be moved to increase bone replacement, which will improve and accelerate orthodontic dental movement. It might be said that corticotomy mechanisms and effects have been documented in recently conducted histological studies. Nevertheless, further studies conducted in human beings are required in order to confirm all these findings. A strict protocol as the one we have is to be followed in order to achieve best results and avoid problems. This starts from diagnosis till finalization. The pros in our approach: easy orthodontic treatment, even trying to make it possible in most of the cases, enhancement of soft tissues, qualities and coverage, enhancement of hard tissue quantity. Bone sets the tone, as we know, so one surgery to enhance everything, no need for extra treatment after orthodontics. The result is achieved much faster, 50% plus faster than in conventional treatment. As we know, time is money. And of course, it's not only that, it's just more predictable. In the dental economics, autologous is always easier to upsell, and no rejection, and also a safer result. Healing is twice as fast. 100% of the patient will talk for this procedure. This is how we get the new ones to this, so to say, procedure that is so dramatically explained to the patients. Holistic dentistry, you have a new clientele segment. You have predictable results, less graft failures, less pre-work for the patient, cheaper graft because autologous, and no one is promoting it. Innovative dentistry, and this will position you as a leader. As a leader, just remember when the implants started being placed, all those doing it were leaders, opinion leaders in their field of work. And this nice picture accompanies all our lectures. The cons: the patient not always accepts surgery because of the fact of more morbidity, which after explained is shown that in reality is not much more. More pain. Normally the pain is easily maintained with conventional painkillers and lasts only a couple of days. And the edema, which is nothing special as you have seen. Technical difficulties of the operation, of course, these are to be noticed. More instrumentarium, of course, it's a complex surgery. It needs an experienced surgeon, and of course it's more expensive. But if you do the math after treatment and corrections and the loss of teeth and so on, it's always cheaper in the longer road. Si vis pacem, para bellum. So if you want peace and if you want a long-lasting treatment, prepare to do what it is needed and what is the best for the patient. This is me and Dr. Baruti, ergo the Gurien Demiraqi approach. We are here in our operation room. Here is the Facebook group dedicated to our type of surgery. But of course, you can find us even in our emails, where we will be happy to answer to you about the questions you might have.